This is chapter 23, which deals with the digestive system. Overall, the digestive system function is dealing with ingestion of food, breaking down those food items, releasing the nutrients from them, absorbing the nutrients, and then the elimination of any waste that has been produced. If we look at this picture here, you can see, excuse me, the diagram of the digestive system, obviously starting up here with the mouth and the oral cavity where the ingestion takes place. The tongue's going to be involved as an accessory structure, helping with the chewing and movement of the food in the oral cavity. You've got your salivary glands, which we'll talk about the purpose of them, and then the food is going to move down the esophagus. It's kind of the over the teeth, over the gums. Look out, stomach, here it comes. Here's the stomach down here now, where you're going to have more churning, breaking up of the food. Both mechanical and chemical digestion occurs in the stomach here. Just one thing I want to point out, over the years of teaching, initially at the very beginning of A&P, I often talk with students, and a couple of misconceptions that I hear about. Two big things. Number one is location of the stomach, and part of that is the fault. As mothers, oftentimes with little kids, they come, oh, my tummy hurts, and you're like, oh, your stomach hurts. And where are they pointing to? They're pointing down more in the almost pelvic area. That's usually intestinal issues. Your stomach is just under the diaphragm. The diaphragm would be right above here. The stomach is just tucked right underneath there. It's a lot higher up. And so that's a misconception. And I'm guilty of it as a mother too. When my kids were little, they come, my stomach hurts. And okay, and I'm thinking, it's not really your stomach. It's probably gas in your intestines. But, you deal with it. The other thing that I have found is there are actually three things. Surprise with the stomach. One of the other things, years ago when I taught in New Mexico, I was at a community college where we actually had cadavers. And there, especially students were really surprised at how large the liver is. They're like, oh my goodness, that is huge. I thought it was just this little tiny thing. No, the liver is much larger than what you think. And the third thing that would often come up is way down here. You can barely see it in this diagram. We'll look at it in a bit. Is this little thing down here that's called the appendix. And that would be the thing students would tell me. That little tiny thing caused me so much pain when it became inflamed. It's like, yes. And one of the problems with the appendix, if it does become inflamed, if it ruptures, it's connected to the large intestines, and all those contents now can be released into this abdominal pelvic cavity. That's another huge whole issue now that you have to deal with. So the food comes down the esophagus to the stomach, then it's going to go in through the small intestines, then the large intestines, through the rectum, and finally out the anus. And this is showing some of these accessory structures that we'll talk about in this chapter as well. The liver, the gallbladder here, tucked underneath this little yellow bit here, you can see part of, is the pancreas. Just so you know, relative speaking, back here is the spleen, which is part of the lymphatic system. So that's just kind of showing the different organs of the digestive system. We do break them down kind of into two parts, the alimentary canal organs. Your alimentary canal, that's your digestive tract. It's about 25 feet if you were to stretch it out. It includes the mouth, the pharynx, the esophagus, the stomach, the small intestines, large intestines, and anus. Now, one thing to keep in mind is because you have the opening in the mouth and the opening at the anus, anything that's inside the alimentary canal is considered technically to be outside the body, which I know sounds strange because you're like, no, I ate it, it's inside, until it is absorbed across the membranes of these various organs. It's considered outside. It sometimes has been described as kind of like having a big tube. If you had a big garden hose, the the water that's flowing through it, that's kind of like the food flowing through your digestive system. And in terms of protection and defense, that's considered outside the body. Now, the accessory structures are going to help with the digestion of the food, help break it down, etc. And that's going to involve, as we said earlier, the liver, the gallbladder, and the pancreas. But it also involves the tongue, the salivary glands, and your teeth. So all of these will be discussed together. In terms of the alimentary canal, there's 4 layers as you look at the histology of it. Those 4 layers, the innermost layer is the mucosa. It is a mucous membrane. It's a very thin layer of smooth muscle in there. Excuse me. The submucosa is going to be dense connective tissue. It has a lot of the blood vessels, lymphatic vessels, and nerves. And then you have the muscularis, which is in most areas, 2 layers of smooth muscle. In the stomach, it's 3. And that's going to help with the mechanical digestion, as we'll see when we discuss the different organs. And then the outermost layer is the serosa, and that's kind of helping to hold all the components together, hold them in place. You got to hold those intestines in place, hold the stomach in place, etc. And so this diagram here is showing the various layers. Excuse me. The lumen, remember, that's always the opening, so that's where the food is going to be moving through. You're going to have the mucosa, then the submucosa, and then as you move out the muscle here, that's the muscularis, and then the outermost layer is the serosa. In terms of nerve supply, when the sympathetic division, remember that's fight or flight, when it is activated, what is it going to do to your digestive tract or your digestive system? Well, it's going to start to inhibit or restrict some of the neural activity. It's going to decrease secretions, decrease motility. If you're in a crisis situation, breaking down food is not your main priority. Running or fighting might be your main priority. Increasing respiration rate, increasing blood flow, but not to the intestines. Parasympathetic division, that rest and relaxation, it does the opposite. It stimulates the neural activity of the digestive system. It's going to increase some of the secretions, increase motility. All of that is going to be helping you with the digestion and absorption of all the nutrients. Yeah, you want to absorb that sugar that was in that donut that you just ate. The enteric nervous system refers to the nerves that are innervating or extending down to the digestive system, and they're going to result in contractions of the muscularis. They're going to result in secretion of some of these GI juices, like intestinal juices, etc. And they're going to respond to the presence of food. The blood supply, what does it have to do? Well, the whole purpose of the digestive system is to break down food, but then you have to absorb it. Well, where do you absorb it? What do you do with it? It's going to be absorbed into the blood, and then it's got to be transported. So you have to have a good blood supply to the digestive system, especially most of the absorption is going to occur in the small intestines, and so you definitely have a good blood supply there. It's going to be transporting those proteins and carbohydrates that are absorbed. Lipids tend to be absorbed and are transported by the lymphatic system, which eventually does drain into the blood supply. You have to supply the digestive organs itself with oxygen and nutrients to maintain their efficiency of doing their work. The celiac trunk refers to the arteries that are going to supply the liver, the stomach, and the duodenum, which is the uppermost portion of the small intestines. Then the superior and inferior mesenteric arteries are going to supply the rest of the small intestines and all of the large intestines. Veins are absorbing the nutrients from that small intestines. Like I say, absorbing all those nutrients from whatever it was that you consumed. And it's going to then drain into the hepatic portal system. Think hepatic always refers to liver. So that means it's the veins are going to absorb those nutrients, and it's going to flow into the hepatic portal system, which then flows to the liver for filtration before that blood then returns to the heart. That way, if anything was absorbed that could potentially be toxic, bad for you, the liver is going to filter it out. The peritoneum is the serous membranous sac. It basically helps hold all the digestive organs in place in that abdominal cavity. I mean, you don't just pack them in and hope they stay, and gravity might pull everything down. It's going to help hold it in place. There's 2 layers with a peritoneal cavity. In between the 2 layers, it's filled with fluid. Once again, that's going to help reduce friction. You've seen this setup kind of before. The parietal peritoneum, that outermost layer, lines the abdominal wall. In the visceral, always think visceral, think of your abdominal organs. So that's going to be the layer that's directly touching all of the various organs. It's going to contain the blood vessels, lymphatic vessels, and nerves, and it's helping to hold everything in place. You hear the term retroperitoneal, which you'll hear that when we talk about the kidneys and part of the intestines. Basically, it's posterior to the visceral peritoneum. So it's either completely or partially out of the peritoneum. That just has to do with the embryonic development, where things end up, essentially. And that's what this is showing, this kind of turquoise color that is showing the peritoneum. The outer one is the parietal. The one right up against, right here is the stomach. The one that's right up against it would be the visceral. And you can see, yes, there are some items. The kidneys, your vertebrae, that is definitely retroperitoneal. It's behind, it's not enclosed within the peritoneal cavity. Part of the large intestines is going to extend out. There are some folds, or what we call the peritoneal folds, extensions of this, and they have different names depending on where they are. The greater omentum, this looks like it's described as an apron. It's like this sheet. It's superficial to the small intestines and the transverse colon. If you do a dissection, it often looks like this thin layer, this thin sheet that you can move and you can look at it. I do have posted some videos in your class from the entomology table, and that one of them I know for the digestive system does have a really nice picture showing the greater omentum. The lesser omentum helps suspend the stomach from the liver, helping to position it correctly. The falciform ligament anchors the liver to the anterior abdominal wall and as well also to the diaphragm. The mesentery anchors most of the small intestines, and then the mesocolon attaches part of the large intestines to the posterior abdominal wall. So they're all working basically. Once again, you have all these organs, and they're helping to hold everything in place relative to each other. So when we talk about digestive processes, there are 6. Ingestion, that's where you're going to take in the food items or drink items. Chew it in your mouth. It's going to be mixed with saliva. This is where carbohydrate, your sugar breakdown, begins. It's actually in the oral cavity, in the mouth. Propulsion, that's going to be the movement of the food throughout the digestive system, moving it from one location to another. This is going to occur by what we call peristalsis. There's going to be mechanical or physical digestion. You take in your food, and it needs to be broken into smaller pieces. Why? Because that's going to increase the surface area, which is then going to increase the rate or the chances of it being absorbed. And it's going to start breaking down chemically faster if you have smaller pieces. Chemical digestion is finally taking those complex compounds, breaking it in chemically into smaller ones. So you might have ingested, you had a nice baked potato. Well, baked potato has a lot of starch in it. Starch is simply a long chain of glucose molecules, which is a simple sugar. Your body cannot absorb starch, but it can absorb glucose. That's the form it needs it in. So the chemical digestion would be breaking that starch compound down into the glucose molecules. Absorption, that's going to occur mostly in the small intestines. And then defecation is removal of anything that you were not able to use. That's removal of the undigested materials. Peristalsis, I say this occurs in several different parts or areas of the digestive system. It is a type of movement, a rhythmic type of contraction. As you can see, this slash circle oval thing here, that would be the bolus, that would be the food. And you get this rhythmic contraction right here, which pushes it down. And then it's going to relax, and then a little bit further down, it contracts. That's going to push a little bit further and a little bit further. And that's what peristalsis is, this rhythmic contraction that's basically pushing the food down. So this is just very simplistic, but it works as far as a diagram of what's going on. Is that, and it, as you can see, it is color-coded, which is kind of nice for you. You ingest your food. So you ate your lunch or breakfast, whatever, snacks, and mechanical digestion is going to start here because you're chewing, you're breaking it up into smaller pieces. Yes, please listen to what your mother taught you when she said to chew your food and don't take huge chunks. So you need to chew the food up here. Propulsion, swallowing. That's going to be, you know, okay, you've got small enough pieces, and here you go. Swallow it, it starts to go down the pharynx, and then peristalsis is going to help move it down the esophagus, and then it hits the stomach. Well, the food's going to wait in the stomach for a couple of hours, actually. You're going to have in the stomach, carbohydrate digestion begins in the mouth, but it's going to stop in the stomach because of the acidity in the stomach. You will start to have some protein digestion occurring in the stomach. You also have mechanical digestion because the food in the stomach, it starts churning. May not be the word you want to hear, but basically you have all this muscle contraction going on. You've got 3 layers of muscle in the stomach. It's going to churn, break that food up even smaller, churn it, churn it, churn it, and then slowly, very regulated and controlled, release from the stomach into the small intestines, where you are now going to continue with all forms of chemical digestion. You're going to have lipid, carbohydrate, and protein digestion occurring. You continue having mechanical digestion breaking down even further, and you start the absorption process, absorbing all of those nutrients as you're breaking it down. You're continuing by peristalsis to move substances through the small intestines. You're absorbing all of these nutrients, and then it's going to move into the large intestines. You'll be absorbing water, compacting the waste, and then getting rid of the waste. That's digestion in a nutshell. Of course, we're going to go a little bit deeper than that. So what are some of the regulatory mechanisms involved? Well, it's going to be involving both nerves and the endocrine system. They have to work together to stimulate the digestive activity. You don't want some of these, like chemical digestion, is going to involve enzymes. Do you want the enzymes being made when you're not eating? No. So it all has to be coordinated and regulated. There's a lot of interactions that occur. It's going to include mechanoreceptors that can pick up stretching. Oh, okay, there's food here. This, you know, the stomach is stretching, etc. Chemoreceptors, which are picking up different chemicals, and osmoreceptors, which are picking up different concentrations of things like sodium, calcium, magnesium, stuff like that, potassium. Some of these regulatory controls begin before you even put anything in your mouth. When you see food, you smell it. Ooh, there is a nice juicy steak that was on the grill and you've been smelling it, and oh, it looks so nice and juicy, and someone's carrying the food, you know, to the table, and you're smelling that. You start to salivate, don't you? Do you notice your mouth is no longer dry? You're having to swallow some because you're producing saliva because your mouth is going, oh, oh, we're getting ready here because we can smell this, we can see it, and I'm hungry. So that some of these, it's like the regulatory controls are preparing you for things before you even taste it, before you even have it in your mouth. Then once it's in your mouth, you start tasting it. And so just be aware that there's a lot of nerves, but there's also a lot of hormones that are secreted in response to the presence of food. And that's going to start getting things ready. You got to get the stomach prepared for receiving the food. You have to get the small intestines prepared for receiving the food and the absorption that's going to take place. So we're going to follow this through. In the mouth, excuse me, we'll start there. You will ingest the food, that nice steak or whatever it was that you saw and you could smell. You start to chew it, and yes, please chew it. Number one, it makes swallowing a whole lot easier, and so you don't want to choke, but you chew it to get it in smaller pieces. It starts to mix the food with the saliva. In the saliva, there are enzymes that are going to help with starting to break down the carbohydrates and also start lipid digestion. Now, usually it's just the carbohydrate. You produce an enzyme that's involved with lipid digestion, but it's not activated yet. It's got to be activated later, but it's like, okay, let's put it in the mix here so we can use it. And then you're going to move that food into the pharynx. The mouth, while you're chewing it in the food, it's going to help moisten. It'll help dissolve. Remember, you cannot taste things unless they are dissolved. Like say you're producing that saliva, that's going to also help in the mouth. You got to clean and lubricate the teeth and the oral cavity. And you want to try to kind of limit some of the microbial activity. There's not a whole lot. There are some substances that have some antimicrobial components to them, but certainly it's not going to kill everything because there are a lot of microorganisms that are present in your mouth. Don't panic. I'm not going to make you learn all the different parts of the mouth, which is now the roof of the mouth. This is known as the palate. You've got the hard palate and the soft palate. Just kind of be aware of this. Obviously, we're going to talk about the teeth in a little bit. The lingual frenulum, that is what you call that attachment that's holding the tongue in place underneath the tongue. So here's the tongue right here. One of the other things, most of you have seen that uvula right here, that little cartilage that's hanging down. You're like, what's that little thing hanging down the back of my mouth? When you swallow that naturally, remember when we talked about respiratory system previously, that is going to kind of flip back and up and close off the nasal cavity so that whatever you are swallowing is supposed to go down the pharynx and not up to the nasal cavity. We really do not want to be like kids and have something come out of our nose. The tongue. What's the purpose of the tongue? Well, it helps with speaking. It helps to position the food for optimal chewing. I mean, you've all been chewing and you don't think about it, but yeah, the tongue's moving. It's kind of helping to move that food around for optimal chewing, breaking it up. It helps to then kind of gather the food into what we call the bolus, position that food eventually for swallowing. The tongue also has taste buds for a taste sensation. And then it's going to help move the food to the back of the oral cavity so it will go down the pharynx. And there's a certain point where it's going down. The salivary glands, they secrete probably a lot more saliva than you thought. It's between 1 and 1.5 liters per day. A liter, for those of you who are not familiar with the metric system, roughly visualize a quart. Or, think of a 2-liter bottle of soda. That's a 2-liter bottle, so that's half of that. That's a lot of saliva. And the purpose of it, the saliva, is to help moisten the food. It helps with facilitating the movement of the food in the mouth, helps form that bolus. It helps with the swallowing. It does contain amylase, which is an enzyme that breaks down starch, so it helps with the carbohydrate digestion. It does contain lysozyme. Lysozyme is an antimicrobial compound, so it will kill bacteria. So that's kind of helping. It's not going to kill everything in the mouth, certainly, but it's going to help. So now your book says that there are 3 sets of salivary glands, the submandibular ones, which think about the words where they are under the back of the jaw, the sublingual, which is under the tongue, and the parotid glands are the largest ones, so kind of in front of your ear. Now, I am making this video just for reference point. Today, as I'm doing the voiceover, it is November 3rd of 2020. They have just recently, in September, published and announced that scientists have found a new set of salivary glands. It's basically behind the nasal cavity. The subaerial glands is the name that they are giving them because of the location of them. They found these, they were doing, like many things, they were looking and doing studies for other things, and were observing a lot of CT scans from thousands of patients, and finally observed, like, wait a minute, what is this? I didn't learn about that in my E&P class. What is that? And they finally realized that, oh, they're very small, which is why they haven't been seen before. But it's a perfect example as our technology improves, sometimes just the techniques we're using, it's like opening a door to, I could never see that before. Isn't this really cool? So this picture is showing here, you've got your submandibular salivary gland here, and there's the duct that's going to release it here. The sublingual salivary gland here, and you've got all these little ducts, basically ductwork under the tongue. Here's the parotid, and then, like I said, the new ones, aerial ones, are going to be the muscle you can't see. It's going to be in that nasal pharynx area. Your teeth is going to help chew the food up. That's what its purpose is. And your teeth have different shapes, as you all know. And you have different numbers of teeth, depending on whether it's your baby teeth or your permanent teeth. Deciduous teeth are known as the baby teeth. You have 20 of those. Your permanent teeth, there's 32. Now, that does include your 4 wisdom teeth. And yes, I know, not everyone has wisdom teeth. Some people are lucky and they just don't have them. Actually, last night was an interesting conversation with a couple of individuals, and we were discussing about how somebody had read a report that they're seeing somewhat you would refer to as microevolution occurring in humans, that humans now compared to 1,000 years ago, the mandible, the jaw is getting smaller. And they're also now saying you're seeing more and more people born that never have wisdom teeth. And we were discussing why that might be. We eat a lot more prepared food now, and the chewing is not quite as tough as it used to be. So could that be a reason? We don't know. But the teeth, permanent teeth, there's 32 of them. You have 8 incisors. These are your what you commonly refer to as your front teeth. 4 on the top, 4 on the bottom. So these numbers are the top and bottom combined. So 4 on the top, 4 on the bottom. Their purpose is for biting the food, gripping it and ripping it apart. It make us all sound like starving maniacs. I'm gonna bite into that, mean just rip it off. Then you have 4, they're known as cuspids or canines. So 2 on the bottom, 2 on the top. That also is involved. They're pointy, so they help with tearing food. Then you have 8 premolars, sometimes called the bicuspids. That's helping to mash the food up. They're not as pointy, so they're not for tearing, they're for chewing more. And then the molars, which are crushing the food and also getting it ready for swallowing in the very back. And so this is showing here the deciduous teeth and then the permanent teeth, the lower ones. And you see it also gives in here about the relative time when they should be coming in. In terms of the anatomy of the tooth, the crown is the portion that you see that's above the gum. The root is below the gum. It's embedded in there in the bone. The pulp cavity contains the nerves and the blood vessels. The pulp cavity that extends down into the root portion of the tooth is known as the root canal. So when you have a root canal done, that's where they're going to be deadening. Oftentimes you've had an infection and they need to deaden the nerves and blood vessels that are there. Dentin is the hard tissue that's surrounding the pulp cavity. And then the enamel covers the dentin in the crown and the part that you see. The tooth is embedded in the gum of the bone, and it's helped to be secured in the socket by the periodontal ligament. Sometimes those of you, either when you were kids, may or may not remember it, or with your own kids, or if you're around little kids when they lose a tooth, sometimes you can see that periodontal ligament looks like this whitish kind of, it's thicker than a thread, but it's kind of like, oh, what is that thing? That's part of the ligament that's helping to hold it in place. So this is just showing once again, the crown is above the gum line, the root's below it. Here's the pulp cavity that has those nerves and blood vessels in it, and then the enamel. And part of the problem with from a dentist standpoint, certainly is that a lot of foods, especially if they're very acidic foods, tend to wear down on this enamel. The pharynx is going to be receiving the food from the mouth. It's going to help close off the air passageways and then propel that food down from the oral cavity to the esophagus. It's going to help lubricate the food as it moves down. Now remember, the pharynx is used for both breathing and digestion. If the food does happen to enter into the larynx or in the trachea, we've all seen it. We've all had it happen to us. What happens? You start coughing very forcefully to push it out because you do not want that getting into the lungs. And so there is that natural reflex. If food does enter the larynx, does enter the trachea, you're going to be coughing until you can push it out. So once again, here is the oral cavity with your tongue. Here's the nasal cavity. So there's that uvula, the little thing hanging down, that little cartilage. So when you normally, okay, when you're breathing, it just hangs down, so the air is going down. And what happens? Well, when you're just breathing, the air comes down, going to go through the larynx, trachea, down to the lungs. When you swallow, the uvula is going to move back and up like this to block off the nasal pharynx so the food does not go back up. And remember the nasal pharynx, like I was just saying, those new salivary glands, they're right back in here. So the uvula goes up and back to close off the nasal pharynx. And then the epiglottis is going to move down, covering right here over the larynx so that food will not go down the larynx and trachea. And instead, this is going to open up a bit. Here's your esophagus behind the trachea, and that's where the food's supposed to go. The esophagus helps propel the food to the stomach. How? By peristalsis. It's going to help lubricate the food. It's behind the trachea. When you're not swallowing, it's very narrow. It's kind of looks like it's collapsed. You have a sphincter, remember, circular muscle, that allows the food to pass from the esophagus to the stomach. Now, this has different names. It used to be known as the cardiac sphincter. Then it was the gastroesophageal sphincter. which makes sense because gastro refers to stomach and esophageal, so the knee tells you the location. And now it's often called the lower esophageal sphincter. 3 different names, it's all the same thing. So why is it there? Well, it's letting the food, when the food hits it, it's going to open, allowing the food to move down into the stomach. It also is normally closed to prevent gastric juices from moving up the esophagus. Your gastric juices are very, very acidic. Your stomach is about pH 2. If those gastric juices come up the esophagus, the lining of it is not protected with a mucous membrane like the stomach is. The stomach has extra protection to prevent it from being basically destroyed and eaten up by the acid. But that layer of protection is not present in the esophagus. So what happens? Well, whenever you've been sick, if you happen to vomit, it burns as you're throwing up. Why? Well, because the stomach acid is burning as it's coming up. Well, that's going to happen at some point in your lifetime. All of us have been sick at some point, whether you like it or not. And I don't know anybody that likes it, but it's going to happen. There's a concern. There are certain eating disorders where individuals will eat and then they will purposely cause themselves to throw up. And there's different reasons they do this. But if you are vomiting a lot, over time, you keep having that acid coming up the esophagus, and it can start to destroy the lining of the esophagus. Very unhealthy in terms of the whole process itself of eating and immediately throwing up. But there's also damage to physiologically to the esophagus. And so I can't stress enough that if you are an individual who does this, please stop. Everyone is too valuable to put yourself through this type of pain. It's going to cause damage. If you know of anyone who is doing this, please encourage them to stop. Have them talk to someone. And unfortunately, a lot of the reasoning behind it has to do with pressures that society puts on us, especially for women, as to, what are you supposed to look like? How thin are you supposed to be? There's all these pressures. Please talk to someone. It's what's on the inside that counts. And the damage, a lot of, especially young people, don't realize what they are doing. But this acid, it's able to come up through the sphincter into the esophagus. And sometimes the damage, if it's just minor, it can repair itself. But sometimes if it's been done repeatedly over a long period of time, sometimes that damage is permanent. So once again, this is showing there's a sphincter here, but this is one we're talking about here, the lower one, that allows the food to enter into the stomach. The process of swallowing is known as deglutition. It's going to be coordinating skeletal muscles of the tongue, of the pharynx, of the esophagus. There's a voluntary phase of it where you're chewing the food and, okay, I'm ready to swallow. You kind of push it towards the back of your mouth, towards the pharynx area. When you hit the pharyngeal phase, that's involuntary. It's the upper esophageal sphincter is going to relax, and that food's going to go down. And then the esophageal phase is also involuntary, where it starts the initiation of peristalsis, moving that bolus towards the stomach. In the stomach, what's the stomach supposed to be doing? Well, it's going to be mixing and churning the food with the gastric juices that it produces to form what we call chyme. It's starting the chemical breakdown of proteins. Any carbohydrate breakdown that was occurring in the mouth, when it hits the stomach, that's going to stop because the acid stops it. But now you start the protein chemical breakdown. Eventually, it's going to release that food into the duodenum, which is the first part of the small intestines. As chyme, it's going to be very closely regulated. You do not release all the food in a continuous fashion. It's like you squirt little bits out, because the small intestines is where the absorption occurs, and you want that to be very closely regulated. You want the chyme to move through the small intestine slow enough so you can absorb all the nutrients. You did not eat all that wonderful food just to have it pass through your small intestines too quickly so you can't absorb any of it. You want to be able to absorb it. So the amount of chyme and how quickly it's released from the stomach into the small intestine is going to be very, very closely regulated. Now, some fat-soluble substances can be absorbed in the stomach, things like alcohol, aspirin. They'll always tell you the stomach has some antimicrobial functions. Part of it is just the fact that it's pH 2. That's going to kill most anything. As I said earlier, it's going to stimulate your protein digesting enzymes. It's also going to secrete what's known as intrinsic factor. That is something that is required for vitamin B12 absorption, which is going to occur in the small intestines. So it's kind of like, okay, food's coming. You got to absorb that vitamin B12 that your bacteria are going to make in the small intestines. Get ready. The stomach is divided or characterized as having 4 regions. There is cardia region. That's where the food passes into the stomach from the esophagus. Why does it have the name cardia? Because it's very close to where the heart is. And just FYI, that's one reason why you have the term heartburn when things do go from the stomach back up the esophagus and it burns because of the acid. Where is that location? Right near the heart. And there have been times when individuals who have heart disease, and if they have a hard time with different disorders like esophageal reflux, where you do have stomach acid coming up the esophagus and it burns and it's painful, if you already have heart disease, it's kind of like, so am I having a heart attack, or is this just acid reflux? My mother used to have that, and so I know at one point the doctor said, well, take some Mylanta to coat the esophagus, and if it still burns, then you're having a heart attack. And we're like, okay, there's got to be a different way. So the cardiac region is just that small area of the stomach where it connects to the esophagus, basically. The dome-shaped part of the stomach is known as the fundus. The main portion of the stomach is the body. And then the pylorus, that's where the stomach is going to connect to the small intestines, specifically to the duodenum of the small intestines. Now, the stomach can stretch depending on how much food you eat. When it's empty, it tends to have these folds that kind of fold in mostly around the body area. And that's what we call the rugae. So when you start filling the stomach, those folds are going to stretch out and disappear. So here's your esophagus. This is the cardia region. So your pyloric sphincter is going to be right in here. Here's the cardia region, the dome area, that fundus. The body is going to be in this area. And then down here is the pylorus, and down here's the pyloric sphincter. And then here would be the beginning of the duodenum. So there's 3 different layers of muscle in the stomach that allows for this churning. So as the food comes down, it can kind of hold the food up here in the fundus area. The food is going to come down here. You're mixing it with the gastric juices, forming that chyme, and you get these contractions that are going to start up here, move down to the pyloric area. It's only going to allow about 3 milliliters at a time to basically kind of, they often describe it as like squirting out. So that release some, and then this is going to close, and you get this big contraction that's going to push everything up, back up, mix it up some more, release a little bit, mix it up more, release a little bit, mix up. Now, every time it's mixing it up, you've got both chemical and mechanical digestion. You're breaking it up in smaller pieces. You're increasing that surface area, allowing more protein digestion to occur, but you're also not overwhelming the small intestines all at once with releasing all the food through there. This is known as the lesser curvature, and this is the greater curvature on this side. So the secretion of the different gastric juices is once again going to be controlled by both nerve and hormonal stimulations. The cephalic phase is where it's a reflex. You smell, you taste, you see the food, even the thought of food starts to trigger the release of some of these gastric. Now, the gastric phase is when you actually have the food entering into the stomach, and that's going to be additional now secretion. So when you first see, there starts the secretion, but then it's going to be amplified when the food actually enters into the stomach. When the chyme enters into the duodenum, you have the intestinal phase now of gastric secretion. So initially that's going to stimulate gastric juice secretion, but then it's going to inhibit it. And this just shows the three different phases of how you're stimulating the different activity and then different things that can inhibit. If you have a loss of appetite, that's going to inhibit the gastric secretions. If you're under a lot of, oftentimes, emotional distress, that's often going to inhibit. There is a mechanism if it's excessively acidic, even more so, even less than pH of 2, because that's what it normally is around. If it drops even less than that, you're going to inhibit. You don't want it to get more acidic, so you're going to inhibit the secretions of it. So once again, you see how the nervous system and the endocrine system are working together for regulating the digestive system. This mucosal barrier of the stomach is helping to protect the stomach itself from all of those gastric juices that are so acidic, as we've been talking about. It's composed of bicarbonate mucus, so it acts as a physical barrier, and then the bicarbonate will neutralize the acid. The mucosal barrier, oftentimes someone has an ulcer, it's interfering with that mucosal barrier, and so then that's when you start to get damage of the stomach lining, because the mucosal barrier is not there. Digestive functions, I've touched on that just a bit ago. Mechanical digestion is that mixing, now you're softening the food, mixing it with the gastric juices, producing that chyme. As I said earlier, about 3 mL of chyme is released into duodenum at a time. The chemical digestion is going to be mostly protein digestion in the stomach. The stomach typically is going to be emptied about 2 to 4 hours after eating. Now, if you have a very high fat content, typically those foods will take longer. The small intestines, overall, it functions by mixing the chyme with digestive juices now. It's going to be moving the food at a slow rate, because the slower you go, that means you're increasing the amount of absorption. You're increasing the amount of digestion and then being able to absorb all of those nutrients. In the small intestines, you are absorbing the breakdown products of carbohydrates, proteins, lipids, nucleic acids. You're absorbing vitamins, you're absorbing minerals, and water. You're going to be performing some physical digestion by what we call segmentation. I'll show you a picture of that in just a second. And everything now is optimal. You've raised the pH back up closer to neutral, so it's optimal for all the various enzymatic activities that many were inhibited in the stomach. The small intestines is about 10 feet long. It's called small because of the diameter. It's only about 1 inch in diameter. There are a lot of different folds within the diameter, or within the surface of the small intestines. We'll see in a bit. And that's going to help increase the surface area for absorption, because that's the main thing that occurs in the small intestines. You have to absorb all those nutrients. So if you can increase the surface area, it means you can increase the rate of absorption. There are 3 different regions of the small intestines. So we're going to start with the small intestines at the pyloric sphincter. That's that opening from the stomach to the small intestines we've been talking about. The first region of the small intestines is known as the duodenum. The bile duct and your main pancreatic duct are going to fuse together and then drain in here. And that's going to be assisting with those digestive juices together that are helping to then break down the lipids and the carbohydrates. The jejunum is the middle section, and then the ileum is the last section, and that is the longest portion. The ileocecal sphincter is where the ileum joins the cecum, which is part of the large intestines. So your stomach would be up here, and then this purplish color is the duodenum, and then you've got the jejunum in the middle, and then the largest section is going to be the ileum. And then it's going to connect to the large intestines right here. The small intestines does include some of these what we call circular folds, villi and microvilli. All of those are increasing the surface area, as I mentioned. The circular folds also work to kind of slow the chyme down. Once again, you don't want it racing through. Slow down so we can absorb everything. And so you've got these folds. So it's not just a flat surface here. You've got folds throughout. You've got the villi. And then within each villi, you have, now these are different magnifications down here. But down here now at the cellular level, see you've got all these little invaginations on the surface. These are the microvilli. But think about it, if that was just a straight line like you see on the box around the cell, you greatly increase surface area. And we've said before, whenever you see invaginations like that, that means you're increasing surface area, which means you are doing something extremely vital and important here. And in this case, absorption of nutrients, which is necessary for survival. In terms of digestion, mechanical digestion segmentation is going to occur here. Basically, you've got the chyme is going to kind of separate, and then it's going to push it back together, which ends up mixing it, and it's going to be mixing it with the digestive juices. That allows for increased absorption. Everything goes back to increasing absorption. That's the whole purpose of why you ate. You were hungry. Why? Because you're at the cellular level. You need those nutrients. There's also a form of peristalsis that's going to occur. It's called migrating motility complex. That's also going to be helping to move that chyme through the intestines. In terms of chemical digestion, the intestinal and pancreatic juices are assisting with protein and carbohydrate digestion. The bile and the pancreatic lipases are going to be assisting with the lipid digestion. Segmentation. So this is showing you've got the chyme coming through. And what happens when it starts to, for segmentation, when these muscles contract more? Well, look what happened here with the yellow portion. It broke it apart and it mixed it half with the blue all the way around. As it's mixing here, so this yellow, half of it went up, half of it went down. The blue, half of it went up, half of it went down. It's mixing this, well, it's also mixing all those digestive juices in there. And so eventually, as you mix it, you're getting better digestion occurring. Break those complex carbohydrates down into the simple sugars that you can now absorb. Excuse me. In the large intestines, what's the purpose here? You're going to be breaking down whatever food residue is left. You're going to be absorbing any water residue. You're going to be absorbing electrolytes. You're also going to be absorbing vitamins. Well, Where did these vitamins come from? A lot of them are made by bacteria that what we call enteric bacteria. They are existing in your intestines. They're supposed to be there. I know for some people, especially when I teach microbiology, they're kind of like, oh, gross. I got all these bacteria in my intestines. Yeah, but they're supposed to be there. In the large intestines, the mucus is going to also be produced that helps with the passage of the feces through the colon. The food residue can be temporarily stored there until defecation occurs. You're going to be eliminating that feces. The large intestines is about 5 feet long. So lengthwise, it's shorter than the small intestines, but the diameter is bigger. It's about 3 inches in diameter versus 1 for the small intestines. So that's where the name comes, is the diameter. There are 4 regions of the large intestines. The large intestines begins at the ileocecal valve that controls the flow of the chyme from the small intestines, from the ileum portion of it, into the cecum. Cecum is that very first part of the large intestines. The cecum has the appendix attached to it. Then you have the colon, which is divided into the ascending colon, transverse colon, descending colon, and sigmoid colon. And then you have the rectum, which connects the sigmoid colon to the anus, and then the anus is the canal, the final part of where you're going to be expelling the feces from. It does contain 2 sphincters. The internal anal sphincter is involuntary, and the external anal sphincter is voluntary. Excuse me. So this is showing highlighted the large intestines now. So here is the ileum. Here is the ileocecal valve. Here is the cecum, this lightish kind of lime green color. Attached to it is the appendix, as I said earlier. The appendix is kind of a leftover. They used to call it a vesidual, which means it's a leftover. There's no use for it now. There's some thought now that we know that there are bacteria that tend to stay here. That might be a means of helping to recolonize at times the large intestines. The concern, as I said earlier, is if this ruptures, you now have entryway from the digestive into your abdominal pelvic cavity. Very, very serious, can be life-threatening. And some people go their whole life without any problems at all with the appendix. So here's the cecum. Here's the ascending colon. Kind of makes sense. Okay, whenever you see colon, think large intestines. Ascending, well, it's moving up. The hepatic flexure is just the name we give this turn right here. And it makes sense, hepatic, because your liver is going to be right up here. Transverse, well, it's going across, transversing across over here to the splenic flexure. Well, your spleen's right up here. Then the descending colon, and then the sigmoid colon right here, which is then going to feed into the rectum, and then the anal canal right here with the 2 sphincters. There's some unique features associated with the large intestines. These 3 main ones, the tenicolai are smooth muscle bands, they're longitudinal muscle layer. Then kind of gives the large intestines a characteristic look to it. It also forms these pouches that are known as the hostra. And the epiglottic appendages are little small fat-filled sacs from the visceral peritoneum. So here are these epiglottic appendages. The hostra are these little pouches. They look like little sacs or pouches. And then this is the muscle I was saying, the tenicolai, this longitudinal muscle. In terms of the bacteria that are present in the large intestines, we refer to the bacterial flora, the bacteria community that is there. These are non-pathogenic, meaning they will not make you sick. Now, some of these, with bacteria, oftentimes they may be perfectly fine in one area of the body, but if they go to a different area, then maybe they could make you sick. What is supposed to naturally be there are non-pathogenic, commensal meaning it's a relationship that they have basically with us where we're helping each other out. By you eating, you are providing nutrients for the bacteria, so that's definitely a plus for them. So what are the bacteria doing for us? Well, they're helping with the chemical digestion. They help with absorption. They also make vitamins sometimes, like vitamin K. Where do you get vitamin K from? E. coli. E. coli that's in, frankly, some people say E. coli that's in your gut. Yes, that's true. The E. coli that's naturally in your large intestines is making vitamin K. How? By digesting the food that you are supplying for it, it makes the vitamin K that then we need. So that's why it's a win-win situation. They are naturally there. There is a balance that's always going on to keep the bacteria from penetrating. Remember, the inside of the alimentary canal is an external environment. So you're trying to keep them there. You don't want them penetrating across the membranes into moving to the interior portion of the body. So there's a balance that occurs there. And just FYI, I did for a while have some summer jobs where I worked in doing water. I prefer to call it water quality analysis. I was testing oftentimes sewage glands. The indicator bug in the United States that we use for testing water to see whether it's suitable for human consumption is E. coli. And why do we use that? Because E. coli is an enteric bacteria. If E. coli is in the water, that means that you have had very recent fecal contamination. Don't drink the water if it's there. In terms of the digestive functions, mechanical digestion, those hostra, those pouches, they do have some very slow segmentation type of movements, contractions that will occur in both the transverse and descending colons that will help break up. It's kind of like, here's your last chance, for any type of breaking up of remains. Peristalsis is going to help move things. You do have strong ways we call mass movement that starts in the transverse colon that's going to move towards the rectum to move any of the remaining items. There's a little bit of absorption. There's a lot of absorption of water. Most of it occurs in the small intestines, but remaining water absorption occurs in the large intestines. And so you've got to be moving those food substances, through the intestines. Chemical digestion, this is really due in the large intestines due to bacteria. And here comes another side effect of those bacteria. Bacteria in the intestines usually are carrying out fermentation because there's a little oxygen there. And one of the products typically of fermentation from bacteria is going to be gas. And depending on what you're eating, sometimes they produce a lot of gas, in which case you may have some issues with flatulence, which is a polite way of saying you got gas, honey. Feces formation and defecation. This is now the final undigested material from whatever it was that you ate. Now, like you've seen, we've mentioned before how it's controlling very much like the control of the chyme from the stomach to the small intestines. If through the large intestines, if the waste is moving too fast through the large intestines where you are not able to absorb the water, then you're going to result with having diarrhea. If it moves too slow, then you're basically increasing the amount of water absorption. You're almost taking too much out of it. There has to be a balance. You want the feces to be somewhat soft, so obviously you can expel it easier. If you're taking too much water out, it's become firmer, and then you end up being constipated. In terms of accessory organs, you've got the liver, the pancreas, and gallbladder. These are three main ones. The liver is going to be producing bile salts. Now, what does the bile do? It helps to emulsify lipids. Basically, it's involved with digestion of lipids and absorption of those lipids. Now, if we skip down here to the gallbladder, what's the purpose of the gallbladder? It's going to store that bile. So the gallbladder, if I can speak, the gallbladder does not make the bile. The liver does. And then what happens is it makes typically more than what you need. And so what happens is the bile gets stored in the gallbladder. It's going to concentrate it. And then as you eat, the bile is released from the storage facility, which is the gallbladder. If any of you hunt, and as you're processing your deer or hog or whatever, don't ever cut the gallbladder. If you puncture the gallbladder, I'll just say bile really, really stinks. When we do dissections in the lab, I always make a point of showing students, this is the gallbladder, do not puncture it because it will stink. Now, in terms of humans, can you survive without the gallbladder? Yes, because your liver's still going to be making bile, you just can't store it. And so that's why anyone who has gallbladder surgery, one thing you are going to have to be careful of with your diet from that point on is your fat intake. Because you still are producing the bile because you still have your liver, but like I just said, you're not going to have excess amounts of it. And so you typically are going to be told to watch your fat intake, essentially. The pancreas produces various digestive enzymes. Some of these pancreatic juices are going to help neutralize the chyme, which is very acidic, and it's also helping to produce bicarbonate. So this picture is just showing, I know it's got a lot of different things labeled here I'm not talking about, but just for reference point, here is your pancreas. Your stomach has been removed. It would be sitting right on top of the pancreas and below the liver right here, so it'd be right in here. The green right over here is the gallbladder, and of course this large thing is the liver. The liver is divided into different lobes. One thing that came out probably about, I don't know, 20 years ago, maybe 25 years ago, part of the liver can regenerate. So one thing that they found, the liver is huge. Like I said, that's one thing that most people are surprised at how large it is. If you have a child that has some disease where they need a liver transplant, an adult liver is too large to put in a child. And someone finally figured out that the left lobe of the liver is much smaller than, say, the right lobe. And just the way the blood supply and nerve supply goes. What they found was that you can take the left lobe of a liver and put that into a child. And then when you give growth hormones, etc., then it will regenerate and grow along with that child. And so actually, if they're doing a liver transplant and you have a donor, you can do 2 transplants. You can take the left lobe, put it in a child, and the remainder put it into an adult. And so you actually are able, one donor is actually able to help 2 individuals, which is often a comfort, obviously, to the family of the donor. Excuse me. This is showing here the pancreas. Once again, the stomach would be on top. This is the, as you can see, it's the common bile duct. It's coming from the gallbladder. So the liver is producing the bile. It sends and stores it in the gallbladder. And then when it receives the stimulus that you've got food coming in from where? Well, from the stomach. So this is the small intestines right here. So the stomach would be right here. Here's the small intestines. And then you've got the common bile duct. You have the pancreatic duct, which comes right in here. See, at this point, it comes into that common bile duct, and then the common bile duct feeds into the small intestines. So you're getting the bile, you're getting the pancreatic juices flowing in. And this is showing a little bit larger here, this gallbladder. Here's a cystic duct. These are coming from the liver itself, and then the common ones are the pancreas is down here. So like I say, you can remove the gallbladder. Just watch your fat intake. And then this just kind of the final summary picture, hopefully having to see everything together with obviously this is the bottom portion of the esophagus. So it's feeding into the stomach through the pyloric sphincter here into the duodenum, which would be back here. This is yellowish right here. That's the pancreas. So you've got, so food, you ate it, chewed it up, came down the esophagus, it's churning in the stomach for a couple of hours. High fat content would be longer. Goes through the pyloric sphincter, down here into the duodenum, which right at the very beginning is where you've got your liver's been producing the bile, stored it in the gallbladder, it receives the stimulus, it's coming down the common bile duct, merges with that as the pancreatic duct, releases those juices into the small intestine in the duodenum. The food is moving through the small intestine, so now it's going through the jejunum, through the ileum, all your absorption, your digestion, etc. is occurring here. It's going to spend several hours in the small intestines, and then finally it's going to go in through the ileocecal valve into the cecum, up the ascending colon, transverse colon, all of this green is the large intestines, down the descending colon through the sigmoid colon, now down into the rectum. It can be held here until you're able to release through the anus. It is going to spend 2 to 4 hours in the stomach. It will spend sometimes up to 6 hours or more in the small intestines. And then depending on how much food you've had, it could spend a couple hours going through the large intestines. When I teach microbiology, and there are several different disorders and diseases that we talk about that often described as having gastrointestinal distress. One thing I'll just say very quickly, kind of relative to that, there is no such thing as a 24-hour flu. What most people call, oh, I got the 24-hour flu. Okay, the flu without any type of preventative treatments is going to be 7 to 10 days that you will be sick. If you're diagnosed with the flu, the influenza, and there are certain medications that you can, if it's diagnosed right away and you start within about 2 days, it might lessen the severity of the symptoms and lessen the time frame probably to about 4 or 5 days. But the flu is not 24 hours. If you are sick and you have what everybody calls a 24-hour flu, it is usually food poisoning. Think back to what you ate 8 to 12 hours earlier, and that's probably going to tell you what you shouldn't have eaten. Because in most cases, it is either food poisoning, and typically if it's less than 8 hours, if you're throwing up, it's because, yes, you've got an issue here, or the bacteria, it's upsetting the balance of that normal flora in the intestines, oftentimes triggering excessive peristaltic type movements. Sometimes, for a lot of them, it triggers the food to move much quicker. And so, because remember I said if it passes through the intestines too fast and you're not able to absorb the water, you end up with diarrhea. And that's often what will happen. Just, like I say, 8 to 12 hours previously, think about what it was that you ate. Hopefully, never have to deal with that.